Well, thank you, Magic. Thank you, Dr. Rosenstein and everyone else for having us here today. Really great to see so many wonderful colleagues, collaborators, people whose work I've so admired over the years. And my name is Joe Gogler. I hold the Robert L. Kane Endowed Chair in Long-Term Care and Aging. You see some of my other responsibilities here, and I'm really pleased to present to you, honored to present to you today the 2025 Robert L. Kane Memorial Lecture. This is the first time we've partnered with Magic on the Robert L. Kane Memorial Lecture. This is actually the fifth Kane Lecture, and we really hope that this is successful. We can continue this partnership. We so believe in the mission of Magic and its vision and how much it aligned not just with our work, but then also certainly with Dr. Kane's work, and hopefully we can use this lecture to celebrate his legacy today. A huge thanks to Ashley Millenbaugh, who is the coordinator of the Robert L. Kane Chair of Various Activities. Without her, this wouldn't have been possible. She did a great job in working both with Magic and Dr. Callahan. I know Dr. Callahan Dr. Callahan had a wonderful set of visits yesterday with many of our colleagues at the University of Minnesota. And again, Ashley, thank you for all your great work. And again, thank you to the sponsors of this event today. That certainly includes Magic as well as the Carlson School Business Advancement Center for Health. The chair, really briefly, I know many of you knew Dr. Kane very well over the years, and it was such a personal and professional thrill for me to assume the Robert L. Kane Endowed Chair back in 2018. It was originally founded and held by Dr. Kane from 1990 for 27 years until his passing in 2017. And really the mission of the chair is very similar to, I think, what Bob's goals were: to advance scientific excellence in long-term care and to shape practice policy as well as teaching and education in this critical area as it relates to aging. And in the end, we see the chair as a catalyst to build aging-specific initiatives, not just within the university and beyond. And I would certainly argue that ongoing partnership and collaboration in rich fashion with Magic certainly adheres to those goals. If you'd like to hear more or learn more about the research projects that the chair funds, you can see this link right here. You can certainly check out this link right here at the bottom. So again, the purpose of the lecture is to honor Bob's legacy. Again, he was the first holder of the long-term care and aging back in 1990 up until 2017. We actually have recordings and presentation slides of all of our prior Robert L. Kane Memorial Lectures. They really are individuals of national and international significance in the field of aging, in the field of geriatrics, and in long-term care. And hopefully some of you had a chance to enjoy some of those lectures in the past, and we'll continue to curate those on our website. Some of the other activities the chair supports, you can see here. It includes our conference. We also host a very robust internship program where we match students with various organizations across the state that really focus on aging services and care. And then also we support the Robert L. Kane Postdoctoral Fellowship, and we're now accepting applications for really what we hope are up to 3 postdocs this year that will be focusing in these areas of aging, long-term care, and dementia. If you're interested in supporting the long-term care chair or learning more about it, please do visit this website, scan the QR code, and again, I'll be here, always happy to answer questions and to hear more about the great work you're doing. So without further ado, I really wanted to introduce a dear colleague of mine, someone whose work I have admired for really the past 20 years or more, and that's Dr. Christopher Callahan. So Dr. Callahan is a physician and researcher specializing in geriatric medicine with over 30 years of experience improving care for older adults. He was the founding director of the Indiana University Center for Aging Research, leading the center for more than 2 decades. Since 1990, he has also served as an investigator at the Regan Street Institute, and today he is the Chief Research and Development Officer at Eskenazi Health, where he oversees efforts in research, quality improvement, learning health systems, health equity, and data analytics. In addition, he co-directs the Regan Street Center for Health Equity Research at Eskenazi Health. So again, we were so thrilled that Dr. Callahan accepted our invitation to be the lecturer today, and I'd like to introduce him now. Thanks, Chris. We also have this very nice plaque for Chris as well as the Robert L. Kane Memorial Lecturer. So thank you, Chris, for that. So appreciate you having you here. So let's get you set up. Here we go, Chris. Thank you. What happened? Oh, that's actually okay. So I was actually saying that we missed the whole stream. By the way, we have, I want to say, how many people online? We do have online attendees. So a little bit over 100 people are also watching this online from across the country. Those of you online, thank you so much. So
What's page down?
just
Here's your, is that your timer? There you go.
just hit the down button.
Go down. All right. Good morning, everyone. Really, excuse me, a pleasure to be here. I connected with some folks I hadn't met yesterday on campus, as well as some old friends like Joe. And I miss these kinds of interactions. I haven't done this for a while. There was a time in my career where I was able to travel around the country a little bit more often than I can in my current role. I think for some of you that might get feeling down about geriatrics or about the world or about anything in particular, coming to a place like this and seeing all the exciting things that are going on, coming to a place like this and meeting young people who are interested in moving this field forward, meeting some of the people a little bit longer in the tooth who have been doing it for a while, but maybe you haven't run into. It's very invigorating. So thank you very much for having me. I don't have anything to disclose in terms of financial support. You can see the past funding that we've had, and I do want to say how much we appreciate funders like the National Institutes of Health, but also some of the foundations that have really committed to work on aging and geriatrics and gerontology, like the Hartford Foundation, and then locally in Indianapolis, big supporters of our work are the Richard M. Fairbanks Foundation, as well as the Regan Street Foundation. Very helpful, and I think all of us recognize what a big role philanthropy has played in this country to move aging research forward. I also want to disclose some what I think are important perspectives, because all of us see this work through a different lens. My family's been hurt by dementia. We've seen this close up, both my family and my wife's family. It hurts, and we know many of you have family members that have gone through this. Many of you have probably been caregivers, or you're about to be caregivers, or maybe you're going to be a care recipient. So I feel like I've seen this from the inside out as well. I've also been around for a while, so I started my clinical practice before there were electronic medical records. And just looking around the room at the gray hairs and the lack of hair, there's a few of you out there who remember we used to write things down in cursive with a pen in a chart if we could find it. Think about that a little bit, what the world's going to look like 30 years from now. Because when I was in residency and when I was in medical school, I wasn't thinking about how my day was going to be changed by an electronic health record. The other perspective, and one of the reasons you're going to see me come back to primary care as the foundation for this work, is I spent my first 10 years in primary care, in a typical primary care practice. Now, I've never done full-time clinical work. I've always been, the majority of my time has been in research, but much of the way I've conceptualized and our teams have conceptualized these models of care builds from this premise that primary care is going to be the foundation of the work. I've been doing geriatric health services research for a long time, and my current role, and probably something like 50 to 70% of my role, is beginning to build the framework for how to integrate social care into medical care. And this is a major undertaking for any health system. It is a big lift. It's not an easy thing to do. I'm going to talk about some of our work trying to extend the resources and the expertise of the health system out into the community, but I am not a neighborhood development person. I'm learning a lot about it. I feel like I've been cloistered in a way on the medicine campus, because once you get out there and see the rest of the world, it also changes the way you think about doing your research and designing interventions. The other disclosure is that I knew Dr. Kane. And right now, imagine that you are giving your talk, maybe you have an abstract that you're presenting, and he's sitting somewhere out there, and you're like, boy, I hope he's in a good mood this morning. And I have seen both sides of it. I really want to thank you for inviting me because of that, though. I was a big fan of his. I grew up in a big family. I have 8 brothers and sisters. I love to argue, and I love to argue with guys like him. So actually, it was a little disappointing if you didn't have an argument with him. So thank you for having me here. It's wonderful to visit, but it's also wonderful to just have the opportunity to remember him. I'm going to do something I don't often do in talks. I'm going to show you some quotes from Bob over the years, excuse me, a little bit longer than we might typically put on a slide. But I want to show you those quotes because let's just say he was irascible. Sometimes he was cantankerous. He could be cynical at times. He just often was right. And he often saw the future. And he often saw that things could be different. And I think as you see the work that we're presenting today, that they're the kinds of things that he'd been talking about for a while. So I'm just going to tell you a couple of personal interactions with him, one that involves Dr. Pacala, but we did a kind of a point-counterpoint on whether the world was ready for collaborative care, and this is a very typical biting, witty thing that he would say, but I agree with 2 of Dr. Callahan's 3 contentions. Coordinated care makes common sense, and it's overdue. The hang-up's the evidence. Then you thought you were about to be complimented, and then here would come, a zinger. The other, at the bottom here, you'll see a paper that's co-authored by Dr. Pacala, but this paper would not have happened without him. I am not exaggerating, because Kane and Morley and I could not agree on this. It was about the role of geriatric medicine and how and why where it fit in the big world. And Jim had to be the adult in the room and kind of work out a truce. And the truce includes a paragraph at the end of this paper that the 3 of us don't agree. I think is pretty funny, but it sort of captured how fun it is to be with him or to argue with him. So we're going to talk a little bit about why we need to reach across the walls. I know in a group that is steeped in aging, you don't need a lot of reasons. It is part and parcel of geriatrics, of thinking about how an older adult fits in the community and in their own home, but I'll spend a little bit of time on that. And then I want to show you what we've been trying to do at Eskenazi Health. And then think back a little bit about what we've seen in terms of the power of writing and advocacy. I also want to acknowledge there has been wonderful progress in the past 25 years. Even though there's a long road ahead, there's so much more that we need to do, but we do need to pat ourselves on the back as a community. Stuff has happened. In the last quarter century, a lot of things have happened. This country has poured a lot of money into the National Institutes on Aging. Again, I mentioned philanthropy. We have had some big initiatives. I'm not going to talk about any of this. I'm not going to talk about the new drugs. I'm not going to talk about diagnostic strategies. I'm barely going to be talking about dementia. I'm going to use dementia as an example. but I want to acknowledge that a lot of progress has taken place. I want to zoom in on this chronic care model that we've all been using as our framework for ages. But in that chronic care model, we tend to stay in that corner where it says healthcare team, because that's the part where we feel we have a sense of control. But really, the chronic care model has a big bubble for community. And how often have we actually done interventions that engage the community? So let's talk about why to reach across the wall. This particular graph ought to be familiar to everyone. We spend an awful lot of money in the United States, and we don't have the health outcomes to show for it. So that red line, which seems to be way out of place, and it is way out of place, that's the United States. Spending twice as much per capita on healthcare and not enjoying the health outcomes, particularly in terms of longevity, of our colleagues in other industrialized countries. And that divergence that you can see on this slide, this does not show the timeline. If you go to this site and you press it, it's actually a video, and it'll show these curves growing over time, and you can go to particular years. But this divergence happens in the mid-70s to late 70s. So it's not like it's been around for 200 years, and it's not getting better. The funny loop-to-loop that you see there is COVID. It kind of gives a little bit more maybe credibility in the data that you can see that kind of a notion. And here's one of the quotes. The feasibility of meaningful, effective programs to alter the prevalence of the major killers in our affluent society, it rests with our ability to find a way of reconciling this need for curtailing or altering aspects of our social behavior with our often espoused concern with individual freedom. Now, if that isn't prescient for the world that we live in 2025, look when that's from, 1977. Lots of these problems, many of these problems that we're talking about, you could have predicted. It wasn't that hard to know that 65 years ago that we're going to have a lot of 65-year-olds because they were already on the planet. They were already here. So often, if you look at Dr. Kane's writings, particularly in some of his books, he has often framed geriatric medicine and chronic care together as if they were the same thing. Chronic conditions he would often talk about, and that was the major issue. And that's where we ought to be spending our money, and that we as geriatricians are role models for how to manage chronic disease. And I show you here the whole chronic care model. Again, old. This goes back to the last century. It's not new. But when we think about our interventions and the kind of ways that we've designed our health systems, how often are we hitting all parts of that model versus that corner of the pyramid that says healthcare? And when you think about that graph of how much we've invested in healthcare now, you can't help but wonder, shouldn't we be making investments in other parts of the system? So I'm going to use dementia as an example, but if your favorite condition is late life depression or urinary incontinence or frailty, it fits in this model. Millions of people are going to develop dementia. They are going to. They're already here. They're in their 40s and 50s. They're coming. We're going to be taking care of a lot of these folks. Most of them will get care provided by their family members in their own home. They are living longer. So this notion of dementia is a terminal illness is like saying birth is a terminal illness, because they have 10 and 20-year trajectories now living in the community, and that is going to be extended by any of the new drugs or treatments that you see. So they might be living in our communities for longer. This is the kind of care that we want. So all of us are at risk of developing dementia if you don't die before you have the opportunity to develop dementia. So we're designing the care systems that we'd like to see ourselves. There is something about dementia, though, that I think we should highlight beyond all of the other chronic conditions, and that's financial toxicity, which may be about to get worse. Because that term, financial toxicity, was actually coined in the oncology literature, and it was coined because the widow is going to get a bill 6 months after the death for the chemotherapy. This is a study by our colleague Amy Kelly that showed that it's 32% of the wealth for people with dementia as opposed to other chronic conditions. 84% of the wealth of African Americans, 58% for widows. But it also casts this long shadow because if the widow spends all of the money on her husband, there's also no money for intergenerational wealth transfer. And if the daughter leaves the workforce in order to take care of her mother, she is not accumulating wealth. So it has this long economic shadow, particularly for women as well, which is kind of, I won't say it's unique for dementia, but it's particularly costly, how we have healthcare set up currently. The majority of the care is in the home, but so is the majority of the risk. I'm not going to read all of those because they're sad, but you can read them, and you could go right now and Google dementia drowned, dementia frozen, dementia found bitten by dog, dementia, shot his wife. This is happening every day in our communities. This is where the risk is. These are the bad things happening to our patients at home. And my goodness, the fraud potential now. Now, someone can take this lecture, capture my voice, send it through AI, and make it sound like me to anyone else in the world, saying anything I want, to say. You're at risk for getting a call from your granddaughter in her voice. These risks are around our older adults now, and they're getting more difficult to see. So many of us see older adults that wonder why they're not taking their blood pressure medicine, but they have no food, they have no transportation. They're worried about housing insecurity. 1 in 11 seniors without enough to eat, and now SNAP benefits are at risk. 92-year-olds starving is another one of these. So this is where a lot of the opportunity is not in primary care, not in specialty care, not in the hospital, but there's a lot of opportunity out there in the community. So let's shift gears a little bit about what this might look like if you were going to take on some of this responsibility for integrating social care into medical care. And it starts with a premise. What if everything we do in healthcare only accounts for about 20% of what makes somebody healthy? What if that's true? Well, one of the things is you wouldn't keep pouring money into healthcare at the rate that we're doing. You would begin to shift some of those resources or put more resources in to these other components of the things that make us healthy. The other part of this is if we do this, we'll all benefit from it. And we were talking yesterday in some of my one-on-one talks about the Americans with Disability Act. We all benefit from that. One of us broke our legs last year, or had a hip replacement, or was out somewhere and you went up a ramp. Or you were out running in the twilight and you didn't fall and break your arm because there was a break in the sidewalk there that you could run up. So when you do these things for a vulnerable segment of the population, it often benefits all of us. And this is the notion of we can make this, it doesn't have to only be about dementia, it can be about what we want for all of us. So the playbook that we've used, and I'm going to come back to this particular National Academy's report a few times, but this was a whole report on integrating social care into healthcare. This is their basic playbook. This is a redesign of healthcare. There's your 5 goals, but try doing any one of them. Who's going to pay for it? You know, how do you change the direction of this behemoth organization? But this is what we have been using for our particular playbook to say, well, if you were going to take the first steps, what would those first steps look like? And this is the part that we have focused on. Again, these bullets are a sub-bullet of one of the other goals that I showed you, and each of them has sub-bullets. But this is the basic framework of what I'm going to present this morning about our progress. And the first is recruit champions. And that's the team that I've been working with for about 5 or 6 years from now. 2 of them came from the community, and this was key. 2 of them were from the world of neighborhood redevelopment and community-based organizations and from faith-based organizations. And if you want to see what might be possible, go to one of the faith-based organizations in Minneapolis and look at what they're doing. They're going to have a food pantry, they're going to have a health ministry, they're going to be doing all kinds of things that they didn't think they were going to be doing as ministers or priests or rabbis. But now they have built up that infrastructure because they're the place where people come asking for help, just like your practices are. All of our clinical practices are where people come looking for help. So we put together a team. We went out looking for places. We talked last night about Minnesota's leadership in dementia-friendly communities and start looking around to see what other people are doing. We are really lucky that we have access to health information technology. We have had to redesign clinical workloads. There's a whole technical assistance group we have funding for. And then we started building out the workforce. Community health workers, doulas, peer recovery coaches, SNAP counselors. Because the primary care system, the geriatrics teams, the social workers, the respiratory therapists, none of us can do this on our own. And then the big step is how you begin to get synergy with our community partners. How do you begin to get into synchrony with people who are out there in the community and doing this work, and they've been doing this work for 20 or 30 years, and what we said multiple times yesterday is you finally knock on their door and they say, where have you been? Like, where have you been? We've been asking for this for so long. We had some key assets at Eskenazi Health. We are the largest FQHC in Indiana, and that includes 14 neighborhood-based clinics. So we are in the high-need neighborhoods, and we have a very good reputation in those neighborhoods. Not because of me, but because of other people. We have a trusting relationship, and when we knock at the door, they open it, and they let us in. We have integrated mental health and public health into those sites. So Marion County Public Health Department is on site, and our mental health team, the CCBHC, is there on site. We have a typical hospital, a very busy emergency room, the busiest in the state. And the whole thing, the entire enterprise, has the same electronic health record, which is key. If you think about the basic architecture of what we do in medicine, this doesn't cover everything, but this covers a lot. Somebody comes in to see us. They either present with symptoms or we are screening them for symptoms. We make a diagnosis. We either treat them right there or we refer them for treatment, and then we do follow-up. They come back and we see how we're doing. Most of those steps take place inside the healthcare system. They're supported by the traditional functions of an electronic health record. Most of that treatment is available within our health system, and you can see if it happened. If I send you to see the pulmonologist, I typically, if they've seen the pulmonologist, I will find a note these days. I'll find the result of the chest x-ray or the blood test. What might that look like if I had referred somebody for food insecurity? That is the notion we're thinking about. This is from a manuscript that's focused very much on food insecurity, and I'm shifting gears a little bit now. We're not talking about the whole breadth of social care issues. I'm using the example of food insecurity. And these were the steps that they proposed that you would need to do this at scale. And it looks very similar. Screening, referral, enrollment. Did people actually take up your particular intervention? You come around to treatment. What were the outcomes of your intervention? And then the cycle repeats itself. I'm going to go through each of these steps of what we've accomplished so far in the context of food insecurity. Why did we start with food insecurity? It was partially because we had feedback that it was in our lane. Food insecurity is in our lane because food is medicine is in our lane in healthcare, because food and poor nutrition are at the root of so many chronic conditions. And food as medicine is quite closely interwoven with lifestyle medicine, things like eat right and exercise. So this was an area where we were able to get good consensus, not only from the healthcare system and our community partners, but from the philanthropy community. This is the kind of thing that they could get behind, because now it doesn't seem like you're asking them to raise money to cure poverty, which is a quote that you will hear often when you're looking for money to support this kind of initiative. So we are now screening all of our patients at scale using the existing features of the electronic health record. And these are real-time reports. You can pull one up 24/7 and see how many folks have we done in the last 6 months, how many have we done total, what's their gender, what's their age, what language, what's their race and ethnicity, and follow it in real time. You can do this at scale, and I would say the electronic health record makes it possible. What are we asking our primary care doctors to do with this? Okay, so you screened everybody. They told you they were food insecure. They might have told you they're a victim of domestic violence. They might have told you they don't have transportation. What do you want your healthcare teams to do about it? That is the next part of the infrastructure. Many places are screening at scale now, but they have not yet gotten to the point where they can offer resources to folks. So we have, again, built within the electronic health record, this self-management capacity. So let's stick with food insecurity first. You say you're food insecure. We have automated 2 functions that allow a patient or their family to self-manage. Some people call this passive navigation. So there's no one involved in it. You screened positive, and by the way, that's pushed out to you before your visit. So that is completed by the patient most of the time. You screen positive. In your after-visit summary, you're going to get this first black and white printout. Printed out automatically. Nobody has to do anything to print it. And it is the food resources in your particular area. In that QR code at the corner, if you scan it, it's going to connect people to Find Help. And Find Help is this blue picture in the corner. If you went right now and got on Find Help, there'd be a Minneapolis version. You put your zip code in and it would show you the closest food pantry. For some people, that's all they need. They just need the number, the information. But think about what else happened. By doing this, the health system just acknowledged that they're willing to do something. You can bring this up. This follows a little bit like the depression literature if you go way back, like 30 or 40 years, where you sort of get a collusion not to bring it up. The doc's not going to ask it, you're not going to bring it up, and if you do bring it up, and the doc says, "How are you doing?" and you go, "You know what, I'm feeling a little blue." And the doctor goes, "Me too, the Vikings lost last weekend." That's a pretty clear indication that they're not in it. That's not something we're going to be talking about today. You've now started to invite people that you're willing to talk about this and that there's resources out there. Our primary care teams, though, also wanted something to do in the moment for the extreme cases. And at 12 o'clock in this picture is a food voucher. So if you say you're food insecure, it automatically prints out a $30 food voucher. Again, it has codes on it so that if you redeem that food voucher, I know you redeemed it and it shows up in the electronic record. So the doc and the healthcare team know this is a person that was not only distributed a food voucher, but they redeemed it. So if you do that, then you're also asked if you would like to send, by the way, those are the food pantries. One's a bus that goes out to the FQHCs and one is one on campus. Some people need more than this, though. This is sort of the passive or self-navigation. Some people need active navigation. And that active navigation needs a new workforce. Now, the names on here, many of you are like, those aren't a new workforce. Like, that's been going on for decades. But their integration is new, and their presence in the electronic health record, and their recording what they're doing in the electronic health record, I would argue, is new. So this team, you can see the names. I mentioned some of the names up here before, but these are now programs that the doc can refer someone to. There's also something happening in that exchange that isn't obvious on here. One is you're beginning to address some of the moral distress of our providers who do feel moral distress that they can write a prescription, but they can't give the person something for food or transportation. So you now have the capacity to refer people to the community health worker who has a protocol that they are to follow, or the SNAP counselors who are going to help you get signed up for SNAP, or medical legal partnership. And one of the key goals of the medical legal partnership is helping you from getting evicted from your home, especially for silly reasons. Nobody gets to stay if they just stop paying their rent, obviously. But people get kicked out of their home for silly reasons. And those are many of the people that we see as homeless. So this is a prevention strategy, prevent the homeless to begin with. There's also a home delivered meals program. And then I think what you see in this too is beginning to see a new clinical culture around who should we distribute this very rare and important resource of a social worker. Like, who should the social worker actually see? He or she does not need to be the person that's doing a bunch of all of this other stuff. We need them, on the tough and the difficult cases and to keep them focused on those. And so it has developed a little bit more of a redesign of what the social workers are doing. I'm going to go through a couple more of these slides a little bit quickly, but I want to show you on enrollment, this is happening. All this is showing is, the last 2 or 3 years. Now, I guess we're getting into 4 years. The last bar is just year to date. And I think this is taken from earlier this year, but we are seeing an increase in referrals to the SNAP counselors. We are seeing the community health workers being used. They're already at capacity. So the system works. Equity was behind this. Behind this program was to get at health disparities as well, and we saw an interesting thing with our data. And the interesting thing we could see was, if you didn't speak English, you were less likely to get screened for food insecurity. And it's very apparent, you know, when you're collecting data this quickly. What you see down here in the corner is the disparity was about 15%, 16.5%. That's the red or the pink there in Q1 of 2023. What's happening here? I mean, these are potentially the most vulnerable group, and they're not being screened. It's all the obvious things you would think of. You know, why you might not take the time to screen somebody because you had to go get the translator, or you had to set up the system, or there wasn't a bilingual interpreter nearby. Dr. Reynoso, who runs this program, this was a part of CQI. You can see it. As soon as you show it to the practices, they're like, yep, you got us. Yeah, that seems like something that we can do. And again, by the end of 2024, the gap's gone. We're now screening them at essentially the same rate. So again, showing the power of getting this into the electronic health record where you can begin to look at things like equity. What happened with SNAP is interesting. We had, this is now about 6 months old, but we've had about 4,000 people referred to SNAP. Only 2/3 of them get through the application. If any of you have ever filled out the application or helped someone, you know why only 2/3 got through. This is a good part to say thank you for everyone for hosting my wife as well, who's here in the front. She can guarantee you I wouldn't make it through a SNAP application. It's terrible, and now they've made it even more difficult. Now, only about 2/3 of those who submit the application get it approved, and it is silly reasons often why it is not approved. You know, you didn't put something in the right spot, or you hadn't dotted an I or crossed a T, and so you go back through. But this is an area where we can say, but this is an economic benefit to the community. If you bring SNAP dollars in, and by the way, Indiana has the lowest rate of SNAP use of any of our surrounding states. We make it hard for people to get on SNAP, but these are the kinds of data that we're beginning to collect to share with our community that this can be done. I'm going to, coming to the last couple of slides here, I want to acknowledge the controversy. Some of our colleagues in the community view this as medicalizing social problems. They do not think that the big, behemoth, costly healthcare system is the right place to put this together. And it's a valid argument. I mean, we're showing it can be done. That's different as should it be done by the healthcare system. There are people within the healthcare system that thinks it a diversion of healthcare resources. We ought not to be using it for this. Like, there are many things that we could put more money into. Primary care is already overburdened. My entire career, because I heard this from mentors who went before me, was you must add into primary care, you cannot add on. And that's part of the design of this. How do you keep the social worker, the nurse, the doc, the advanced practice provider, whoever, how do you keep them focused on the work that they actually need to do, but acknowledge that our clinical practices are like Grand Central Station. Lots of people coming and going, and you're sorting them and sending them on the right route. Once you open the door to this as a healthcare system, there are thousands of partners. In the Indianapolis metro region, there are 4,000 community-based organizations. And I said 1,000, 4,000. If you go statewide in a state like Minnesota, they're all struggling. They would all like to partner, and it is very difficult to make decisions about who's the right partner to do what. I'm going to end talking about what I think is a very aspirational goal. It is really reaching even further out into the community, and that's our health engagement zones, which used to be called health equity zones. And then about a year ago, we were invited to change them. And I really do hope my flight isn't canceled now for having said that out loud. These are 3 of the highest need neighborhoods in Indianapolis. Very high social deprivation index if you're used to that particular metric. These are the areas that were redlined in the 40s and 50s. These are the areas where the industry left in the 60s and 70s, except the people didn't leave. It is the largest concentration of African Americans, largest concentration of the new Hispanic population, largest population of our new African immigrants. So very high need neighborhoods. We have an FQHC location in each of those neighborhoods. And what we did, this is now in its 5th year, and this is our community development expertise. I mentioned one of them, she comes out of the faith-based community that had already been doing a lot of this work, and one came out of neighborhood development background. And I know it looks silly when you look at the first 2, but any of you used to dealing with healthcare know that the first 2 are probably a good thing to remind people of. You're here to meet people, and you're here to listen with humility, and you weren't invited to bring the answers before you'd listened. This is a long process. It's an expensive process from the perspective of human capital that the health center is paying for. So we're in phase 5 right now. We had a very generous gift from the Fairbanks Foundation, $3 million. Half of that is going to go down to the community-based organizations that we're working with to help build their infrastructure and build the interface with the healthcare system. And we are beginning to collect the data that would help us know if this worked. It's a major undertaking. This is a full-time job for 6 people now. I'm involved in it, but I don't spend as much of my time with it as the folks who are leading it. All right, I'm going to end with the power of writing and advocacy and bring us back a little bit to Dr. Kane, but also to zoom in again. Remember, on our chronic care model, which has been around for 30 years now, positive policy environment, and what is our role, what is our duty, what is our obligation to be influencing the policy environment. And you all know that Dr. Kane was a writer and an advocate. One of his quotes that I liked was, "Members of the Society of Professional Journalists believe that public enlightenment is the forerunner of justice and the foundation of democracy." Written in 2005, so 20 years ago. There's a fascinating interview that one of your, I don't know if she's a journalist or an anthropologist, but I'd like to think of her as an anthropologist going into Kane's natural habitat. And she has a very long interview with him. And within 5 minutes of the interview, he points out that he was at the March on Washington. And I can't picture it. Well, he's a very young man at that time because he hasn't come to Minnesota yet. He hasn't even gone to UCLA yet. And I'm going to show you what he was doing. But I think sometimes we forget his advocacy, and he did have a background in philosophy and science, of course, but he was also witty. And I challenge you to pick out your favorite title here of one of his editorials. My personal favorite is One Flew Over the Cuckoo's Nest, because I think it's too cute. And I would imagine that Rosalie and he had a huge fight that he was not going to title an editorial Premature Geriatric Exportation. And God knows how he got that published. But these are really wonderful to read, and they're timeless. And I'd really encourage you, when you're thinking about, designing something, and this is well beyond long-term care. There's a lot of advocacy that goes on here. Some of us are the target of some of these editorials, so I would point that out as well. Here's a long quote, but this is 1963. 1963. Yeah, it's the interview that Lauren Klafke, I guess her name is, did with him. And he says, I guess one of my epiphany moments was when I was a second-year medical student. I spent the summer on the Lower East Side of New York at a place called the Governor's Ambulatory Care Center, which was an innovative community health organization that was really trying to integrate medicine and social factors. This is not new. This is not new, and again, prescient. And people have been trying to do this work for a long time. It's all about implementation, and it's all about implementation in the current context, because even if you successfully implemented this back in 1968 or whatever, the world changes, and so you have to adapt to those changes. And that's my last slide. I think he said, so I got interested in the whole question about how you integrate medicine into the larger society, and that's where we are now. Thanks so much for having me here and for your attention.
Thank you. Yep. So everyone, we don't have floating mics in the audience. I just ask you to raise your hand and ask questions. Dr. Callahan will repeat the questions for the online audience. And actually, if we have questions from online, we can have Chris ask those too. So questions?
Yes.
Ed Ratner, I'm a geriatrician.
Does this go? We could do that. Yeah, but we could do this.
Some of what you're describing sounds kind of like the one-stop shop that some of the area agencies on aging try to say, how could we help people just find their community or social services, all of them through one organization. Do you see the FQHCs potentially, or the healthcare centers in the community, potentially representing that one-stop shop for both medical and all the collection of social services?
Thank you. Thanks. Great question. One of our FQHCs, yeah, I'll repeat the question. It's this notion of the reflection was some of what I was talking about looks like a one-stop shop. And we have had other organizational structures, we'll say, like area agencies on aging that have sought to do that, one-stop shop for older adults or people with disabilities looking for services. One of our FQHCs, it's the newest one, is a two-story building. And the second story is the FQHC and follows all the rules and regulations of an FQHC. The first floor of that building, though, has many of these services that you're describing. To show you how, what it could include, for example, is the local community development corporation has an office there. The Marion County Public Health Department has an office there. We have also put some hospital-based services there at the request of the patient. So the radiology is there. And radiology is there not just with a chest x-ray, but with mammography and an MRI and CT scan. That notion, I think, may be an important way to go, because the other thing that it becomes is that entity itself becomes an economic driver in that neighborhood, an employer. It's on the bus line. So you mentioned a few, like Area Agency on Aging. They're not in there in this particular instance, but you wonder if that is the future. There are a lot of reasons why you can't plop an Area Agency on Aging actually within the FQHC, but like you can do creative co-location.
Thanks, Chris. That was terrific. So the question of should we do this as integrated into healthcare or the other possible way, and that is as a country to put more resources into social care and medical care. So out of the 34 OECD countries, there's only 2 that spend more on medical services than social services. Us and Mexico. We spend 30% more on medical services than we do on social services. All those other countries in that slide you showed, as you know, that do better than we do, spend up to 2 times as much on social services as medical services. So, shouldn't we be trying to do that? They do it better than we do. And although that may just be politically untenable. I don't know if you can comment on that.
Yeah. Thank you, Dr. Bacala. So his question for those of you online was, when we were talking about acknowledging controversies, one of the controversies is, does this belong inside healthcare? And in the slide Dr. Bacala is referring to where we spend so much more money, if you looked at the total expenditures of those countries, where you included social care and medical care, it begins to even out. You know, the expenditures even out because they're spending. But what's under social care, we should point out, it includes things like education, which is very key to all of this as an educated populace. So I don't know the answer to Dr. Bacala's question in the long run. I would say in the context of where we are in 2025, we have to do it. And the reason that I think we have to do it is because this year, in the coming months, your emergency room is going to be feeding hungry people at great expense. And your clinicians are going to experience this moral distress of this person that they've been taking care of for a decade lost their Medicaid. I'm not making a political statement. I'm saying that is going to happen. So
Testing.
that was move on to the next question. Other.
First comment, I would speak in support of continuing the integration of the social aspects into the electronic medical record, because I don't think we can practice, like you mentioned, it's 20% of what I used to do in the office actually has an impact. Everything else is affecting the health of my patient. It's all on the outside. Having said that, what I'm curious about, if there's a short answer to how does one determine what the resources are in my area? For instance, you mentioned there's 4,000. I assume those have been integrated into the electronic medical record, meaning somebody figured that out and entered it. How did you learn it? And did I understand you to say one way to do that is to Google something, find help or something?
Yeah. Thank you. The question is so you say, for example, you've asked a patient if they're food insecure and you want your EHR to be able to refer that person to local resources. How does that data get in? There are multiple companies. I'm only mentioning one. I'm not a spokesperson for Find Help. We just used Find Help as one of them, and Find Help ! But there are 3 or 4 of these in the country that have begun to map out and document social services available in the major cities. And if you Google Find Help, it'll show you those services. Now, one of the things that they offer, though, is health system specific instances of it, so that you can know how often a patient came to the portal through you. In Indianapolis, we are a little bit fortunate that the major health systems in Indianapolis, they all chose the same platform. And one of the things it does is you get a little bit of a group dynamic where if a place closes, somebody notices that it closes and it comes off. It even allows rating. It allows a person to go, well, they really treated me nice, or they didn't. So that, it's like the old, and I'm sorry to use the word old, but the Rainbow Book, if some of you remember the Rainbow books, that it had different colors and was out of date the day they printed it, and you would go look for the Rainbow Book and where there was a hot meal available in the area. Fall hazard there.
I don't think I have so much as a question as more of a comment.
Yep.
Thank you so much for your presentation, and this is more kind of out of respect for Bob and Rosalie Kane. I'm Amanda Johnson with Care Providers, and I think when you speak of advocacy and the importance of it, Minnesota's a bit lost on our goal. We don't have a vision for seniors on our legislative agendas or in our funding agendas as far as Medicare, Medicaid dollars and how we spend them. So all of this is so important for us because all of the work Bob and Rosalie did for decades, and particularly as we move into institutional care, which is a horrible word, but for assisted livings and particularly nursing homes, we are unfunded. You work so hard for private rooms and whole changes in how we take care of people in home-like environments, and we're really going backwards in that area. So I felt like I should say something because I worked for many years on different projects with Bob and Rosalie. So thank you.
All right, thank you. For those of you online, the comment was sort of an underline of the importance of advocacy and continuing some of the work that Bob, the Doctors Kane, worked on, some of the things we pointed out here today, and the observation that some of the things that are happening currently either in state legislatures or federally is going the opposite direction of how some of us think it should go.
Thank you so much for a wonderful talk. So I wanted to have a question about future geriatric education. So when Dr. Bob was second-year medical students already think about social care. So I remember 25 years ago when I was a geriatric fellow, so I gave a talk about weight loss in the old people. At the end of my talk, Dr. John Morley stand up in the audience and say, Dr. Chen, why you did not mention Meals on Wheels? So as a first-year fellow, I was internal resident. I never heard about Meals on Wheels on your slides. And Dr. Morley said, Dr. Chen, you need to learn something new, about geriatric. So my question is, how do you integrate education on resident medical students, fellows about social care? Because we do not have enough education for those trainees. What happens 10 years, 20 years later? Nobody care about social care.
Yes, another great comment. So for those of you online, the comment was, even going back 20 years ago, you would have someone like a Dr. Kane mentioning the importance of social care factors, and a program like Meals on Wheels, who are one of these community-based organizations, often funded through the Area Agency on Aging, to reach out to homebound seniors and others to deliver meals. And are we teaching our medical students, our nursing students, our social work students, all of our students about the importance of these social factors? And It's another area that I would put geriatric medicine in. Is some places are going backwards. You know, that you're seeing less content. It is an interesting thing to see debates about what ought to go into the curriculum. You know, literally fights over what can fit into the curriculum and what can't. I think part of this, and I didn't show it, but it's a Lancet article, and I think it's like 1968 if you want to find it, but it's one of Bob's first publications. And it's about exactly your question, and what he's advocating for is that in a medical school, a student should have to go do home visits. And in doing the home visits, they were to make a diagnosis of that home, but they were also supposed to make a diagnosis of the community. I mean, it's a fascinating editorial that he's writing in response to something else, and he's describing this this place that he was working and the mentor that he was working for. So it was a great comment.
Very good, Chris. Join me in thanking Dr. Callahan, please. Thank you so much, everyone. The program will begin again at 9 o'clock. We really appreciate your time here. Thanks.
10 o'clock.
Or 10 o'clock, pardon me. Chris, that was great.